All right, good morning, everyone. This video is going to focus on restraints, what their indications are, when we do and don't want to use them, and a big thing with restraints, documentation. So let's get started. When is it appropriate to use restraints? The first and foremost thing you want to know is that restraints are always going to be the last resort option for your patient. If there is ever anything you can do that is less than restraints, like reorienting your patient, giving them a medication, you're always going to activate that intervention before you activate restraints. So, when is it actually time to go ahead and go to restraints? Three big questions. Is your patient a danger to themselves or others? If your patient is actively trying to harm themselves or combative and trying to harm their family members, friends, the team members, anybody else in the room, if you feel like somebody is physically in danger, it is appropriate to use restraints. We want to prevent harm to the patient and to everybody else involved, of course. Second question, are they trying to pull out their IVs, their airway, any drains, any other equipment on them that's vital to their safety? This kind of goes back to the first question in a way because, for example, if the patient is intubated and has an ET tube, they're not able to breathe on their own, but they're trying to pull out that breathing tube. Well, if they pull it out and we lose that airway, that patient could code. That patient could actually die because we don't have a way to ventilate them. So if they're trying to pull things out because they're delirious, disoriented, they don't know what it is appropriate to use restraints in that instance because the patient is a danger to themselves. That's just a specific question to the medical environment that if an NCLEX question asks about, is it appropriate to use restraints? And they tell you in the stem of the question they're trying to pull out one of these types of tubes or devices, it will be appropriate to use restraints. And the last thing is for our delirious patients. This is very common in the intensive care units. Patients don't know where they are, they're afraid of the team and everything that's going on, and they become a huge risk to themselves because they don't know where they are, who they are, what time of day it is, and that's very, very scary. So they begin to try and pull things out, their IVs, their airway, and hurt themselves, hurt the team members because they don't know who you are. So for delirious patients that are a danger to themselves or others, it is appropriate to use restraints. Just remember that we always remove restraints as soon as it's possible. If your delirious patient starts to kind of come around and understand what's going on, if your patient who was a danger to themselves is no longer trying to hurt themselves, always discontinue the restraint order and do other interventions. Redirect them, orient them to the situation. If your provider has sedation ordered, that would be appropriate to give as well to keep them comfortable and safe. We always want to get rid of those restraints just as soon as we can. So let's talk about some of these different types of restraints if you do have to use them. The first one, and one of the most common, is a soft wrist restraint. This is basically kind of a bracelet that wraps with Velcro and then a clip around the wrist of the patient. It can either be 2 points, meaning just the wrists or just the ankles, or 4 points, which in that case, all 4 extremities would have one of these devices on them. Those loops then go down and get knotted around an item that cannot move. So for example, you cannot tie these to the bed rail because a bed rail can be moved up and down, and that would negate the effectiveness of the restraint. No chairs, no rolling equipment. It has to be tied to like a loop on the bed itself that cannot move. Most hospital beds have a place where restraints can be tied. And you'll tie them in a very specific knot called a safety knot, where when the patient tries and tugs, the restraint does not move, but there is a very quick way for you to release that knot in the event of an emergency. For example, if there's a fire and you have to get your patients out very quickly, you would want to be able to release that restraint immediately. So that is the soft wrist restraint. Again, it can be 2 point or 4 point. And then the other picture over on the right here are our mitt restraints or posy mitts. So these are just like big poofy gloves that will go over the finger of your patient and then be velcroed or clipped around the wrist. This is for your delirious but kind grandma who doesn't know what's going on, so she's trying to take the oxygen off her nose. She's trying to pull her IV off. She's not necessarily violent. She's not trying to hurt herself or harm you. She's just upset because she doesn't know what's going on. She's very confused. And when you put these mitts on her and cover her fingers, it takes away her ability to get those tubes out, pull the oxygen off her face, do whatever it is she's trying to do that could be a harm to herself. These are probably the most commonly used on some units. They're really the least invasive. There's a low risk of skin breakdown when they're applied correctly, and they're not quite as you know, they don't look quite as bad to family members because they just kind of look like big poofy gloves that a kid would wear out in the snow. So like I said, we see this commonly on older patients who don't really know where they are and are a bit confused but aren't necessarily violent. This next type of restraint on the left, it's called a posy bed. This one looks like it's a bed more for an infant. They make these both for adults and pediatric patients. It's essentially just a closed environment that will keep someone contained. It's all mesh and it's all padded and soft, so the patient should not be able to hurt themselves whatsoever, but they can't get out. It closes all from the outside. There's no zippers or ways to open it from the inside, and we're able to always directly have visible observation on the patient. They're never out of our line of sight. So this is also not for the patient that's actively trying to harm themselves or that's violent, because a patient could do that in this bed. This is again just for the confused patient that's a falls risk, trying to get out of bed when they shouldn't, and this keeps them contained and safe. Last but not least, over on the right is our posy vest. I don't see this one used very frequently, but it essentially just straps on like any vest, kind of crisscrosses over in the front, and then you have those loops going down or those strings going down at the bottom that will get tied to the bed in that same kind of knot we were talking about for the soft wrist restraint. It'll get tied around something that doesn't move in a slip knot where the patient won't be able to get up. It will keep them down in the bed, but you can release the knot very quickly as the nurse in case of an emergency. This will completely immobilize the patient in the sense that they are not able to move their trunk at all. So if you restrain them laying down, they're stuck laying down. If you restrain them sitting up in the chair, they're stuck in the chair. But they have free movement of their arms and legs. So again, if you had an older patient that didn't know where they were a falls risk, but they continued to try and get up, this would keep them, maybe it's nighttime, they're asleep, and this would keep them in bed. But they could still move their arms and not feel quite as tied down. Now, for a patient who's actively trying to hurt themselves, this might not be the best option because they could still get a hold of something with their hands. So those are just 4 of the basic types. That should cover any type of restraint that would be brought up in an NCLEX question. All right, last but not least, as I alluded to in the beginning, we're going to spend an entire slide on the documentation of restraints. Because these are a last resort item and they're not really used that often, documentation is paramount, and there's several things that must be documented anytime you're placing a patient in restraints. First and foremost, the start and stop times. You need to document to the minute exactly when this restraint was initiated and when it is stopped, because there's very strict policies about how long they're allowed to be on. Secondly, the reason that the restraints are indicated. You really want to validate why you have had to escalate this patient to being in restraints and why another intervention is not appropriate at this time, because that kind of covers you as far as a nurse, saying, yes, these are very much necessary. If they weren't necessary, you would need to discontinue them. Thirdly, the plan of care. This first and foremost goes into the reason the restraints were indicated, but even more importantly, talks about your plan for helping the patient to progress to a place where they don't need restraints. We need to have plan of cares for these patients, all patients, but specifically restraint patients, that move us towards getting out of restraints, because it's very important to limit the amount of time that they are in restraints. The last item that must be documented and documented very, very thoroughly is your assessment. Of course, we document an assessment on all of our patients, but it is especially important when your patient is in restraints because of skin breakdown. If we just leave a patient in restraints for a prolonged period of time and we're not checking on them and looking under the restraints for skin breakdown, you will undoubtedly get pressure injuries and skin breakdown, and the hospital is responsible for that because we caused it. We put this patient in restraints and caused that skin breakdown. Your due diligence as a nurse is to check that skin, look under the restraints, validate that there's 2 finger breadths width of room between the restraint and the patient's skin, that there's no moisture, redness, that you're giving them bathroom breaks and all of those things that are required of us. And you have to document all of it. So check for that skin breakdown. If you see any redness, you need to initiate preventative measures such as a foam Mepilex, a barrier cream, whatever's appropriate depending on the area that the restraint is on for that patient. If you don't document skin breakdown and the next nurse comes in behind you and sees breakdown already present, you will be held responsible for it. So document, document, document these restraints. Okay, let's finish this video up with a quick NCLEX question to test your knowledge on restraints. Which of the following situations represents an appropriate time to place your patients in restraints? Select all that apply. A, when they're trying to pull at their lines, tubes, and drains. B, when their family member asks you to. C, whenever you feel it is necessary. Or D, when they are a danger to themselves. Okay, the correct answer was A and D. A is correct. It is always going to be appropriate to place your patient in restraints if they are trying to pull out their lines, tubes, and drains. This comes back to the fact that that makes them a danger to themselves. Anytime a patient may cause harm to themselves or others, restraints are appropriate. The other correct answer was D. D was when their patient is a danger to themselves, and as we've stated time in and time out, that is the #1 indication for placing your patient in restraints. So if any of the NCLEX questions that you get about restraints indicate that the patient is trying to hurt themselves or hurt somebody else, it will be appropriate to place them in restraints. B and C were both incorrect answers to this question. B was if a family member requests restraints. This is very uncommon, but every once in a while a family member will feel safer with their loved one placed in restraints, especially if that family member is in distress, which sometimes happens when they see their family members become agitated. But just because a family member asks you to does not make it appropriate. You, as the nurse, need to use your best judgment to determine if the patient is a danger to themselves or others, if they're trying to pull at their lines, tubes, drains, etc. If you don't feel it is appropriate, or if you feel there's something else you could still try to do, such as reorient their family member, narrate their cares, implement a day-night schedule, try to help them understand what's going on. If your provider has some PRN sedation ordered that would be appropriate to give, you as the nurse need to educate your family about those other interventions and why you're choosing to do those first rather than immediately put the family member in restraints. Lastly, C was whenever you feel it is necessary. This is a very incorrect answer to this question. Just because you feel it's necessary does not mean you can immediately initiate them. If you feel restraints are necessary because your patient is a danger to themselves or others, you need to immediately speak with the healthcare provider, validate your concerns, give them your assessment and your recommendation, and if they order restraints, then you may initiate them. You must have an order to initiate restraints. It is not within your scope of practice as a registered nurse to initiate restraints without an order from a provider. That is why C is incorrect. All right, that was an example of an NCLEX question for restraints. Review this video if you have any questions and check back for more. Thank you guys.